Hello friends, welcome to this module on hepatitis B. So from hepatitis B, you get a lot of questions in your exam, lot of questions. So we'll study this topic in a bit detail, right? So what actually is important about hepatitis B? What actually is the special thing about hepatitis B? So as you know that viral associated hepatitis, we have HAV, HBV, HCV, hepatitis D, hepatitis E. All these viruses are mostly RNA virus, except for hepatitis B, which is a DNA virus, which is basically a DNA virus. So this is one thing that you need to know about hepatitis B. Now, hepatitis B is also known as the Dane particle, and it belongs to the family of HepDNA viridae. HepDNA viridae, and as I have already told you that it's a DNA virus. But there is a particular importance about this DNA virus. It is partially single-stranded and partially double-stranded DNA. So it has got a partially single-stranded and partially double-stranded DNA. So this is an important piece of information that you need to know. And another important thing is it's a DNA virus that behaves also like a retrovirus. So what is the meaning of that? We'll come to that in subsequent slides. So what actually is the structure of hepatitis B? So you have to remember three numbers. One is 42 nanometer, second is the 27 nanometer, third is the 22 nanometers. Okay. So the intact virion of hepatitis B is basically 42 nanometer particle. So the intact virion of hepatitis B is a 42 nanometer particle, whereas you have certain spherical and the filamentous forms. You have certain spherical and the filamentous form which are 22 nanometer particle. Now, if you do the electron microscopy of the hepatitis B virus, you will see that this 22 nanometer particle is the most abundant particle. This is the most abundant particle, whereas 27 nanometer is the nucleocapsid core. It is the nucleocapsid core. So three numbers you have to remember. One is 42 nanometers, 22 nanometers, 27 nanometers, right? So we are done till here. Next comes the structure of the DNA virus. So it has got basically 4 genes. It has got 4 genes. What are they? It has got a S gene, it has got a P gene, it has got a C gene, and it has got a X gene. So there are 4 genes, and P is the largest. P is the largest. Now I have mentioned that it is a DNA virus that behaves like a retrovirus. So we'll come to that when we discuss about the P gene. First, starting with the S gene. So what does it synthesizes? It basically synthesizes your surface antigen. The S gene and its products, one of them is directly from the S gene. So whenever the translation is taking place, it depends whether it is just from S or it's S plus pre-S2 or it's S plus pre-S1. So if it is only from S, what we get is a hepatitis B surface antigen, which is the major product. Now, if you have S plus pre-S2, then you get what is known as the middle protein. And if you have all three, then you would get what is known as the large protein. Coming to the P gene, I've already mentioned that it is the largest of all genes. It is the largest of all genes and has got DNA dependent polymerase activity. And why I have been reiterating on the fact that it also behaves like a retrovirus, because it has got a RNA dependent reverse transcriptase activity. RNA dependent reverse transcriptase activity that makes it behave like a retrovirus. Then comes your C gene. So if you go through the diagram, basically it has got a C, the core region, and it has got a pre-C, pre-core region. So there are two different products that come out of it. From the C gene, if the translation occurs at the core region, what you get is the core antigen, or you get what is known as the HBC antigen. Now this HBC antigen is basically present at the nucleocapsid core, right? Now this HBC antigen is not seen in the blood, but the antibody that comes out of it, anti-HBC, this is seen in blood. Okay? So HBC antigen is not seen in the blood, but anti-HBC is seen in the blood. Other is the pre-core region, from where you get the E antigen, and you get HBE antigen and you get anti-HBE antibody. Now this is basically the marker of infectivity. So you can understand if HBE antigen is positive, that means that patient is highly infectious and the virus is undergoing active DNA replication, right? Next, come to the serology part. Now this diagram is actually very important. We need to focus on this diagram. So what is this diagram showing? You have a infection with hepatitis B. When you have an infection with hepatitis B, even prior to the appearance of jaundice or with the appearance of ALT, the first thing that rises is your surface antigen. And after that, what you get in the blood is anti-HBC. As I've already mentioned, you won't get HBC antigen in the blood. So you get IgM anti-HBC, right? After a certain span of time, this becomes IgG anti-HBC. And when the surface antigen falls, then the level of surface antigen falls, this ultimately becomes the anti-HBs. And there is a particular period where there is a gap. This is known as the gap period or the window period. Now, in this period, your hepatitis B surface antigen levels have fallen down. Your anti-HBs levels are not in your blood. So how will you diagnose whether you had an infection with Hep B? It will be diagnosed by IgM anti-HBC. Because this is the only antibody at this point of time which is elevated, right? Other than that, what you have is, with the rise in HBsAg, you can also have rise in HBe antigen. What else? After that, you will have rise in transaminase, and once the transaminase rises, you will have jaundice. So transaminase elevation occurs first, followed by jaundice, right? So this is a very important diagram. We will discuss this subsequently also. So the first marker to appear in blood is the HBs antigen, right? Now we've discussed about anti-HBC, the important of which is IgM anti-HBC, which is seen in the window period, and IgG anti-HBC, this is a marker of chronic infection. It is seen when it has become chronic infection. Now this HBE and anti-HBE, I have mentioned that this is a marker of infectivity. This is a marker of infectivity. This indicates that you are having a active, this means indicates you are having an active DNA replication of the virus. Now we'll read about certain variants of hepatitis B. What are the variants we can read of? One is the pre-core mutation. So if you remember, when we are talking about the C and E antigen, you see one we have C and the other is the pre-core region. Which basically synthesizes E antigen. So if there is a pre-core mutation, the E antigen will not be synthesized. So in that case, what will happen is you will be fooled by the fact that the patient has the following serology. HBs antigen is positive, anti-HBE is positive, right? Anti-HBE is positive and IgG anti-HBC is positive. So what will happen is you're going to feel that the active DNA replication is not occurring, and you will feel that the patient is not infective. But what actually is happening is that patient is not able to synthesize HBE antigen. This patient is unable to synthesize the HBE antigen, and ultimately these patients they progress to develop liver failure. Because we thought that the DNA replication is not happening. So retrospectively, you can diagnose these to have pre-core mutation. From your clinical question, what would be your clue? Your clue would be, this would be the serology that you would get, and you would get a HBV DNA levels are relatively higher, considering the fact that patient is HBE antigen negative and anti-HBE positive. Okay. Next, we'll talk about what are the escape mutants. Escape mutant means they escape the protective effect of your antibody. So you have anti-HBs in the blood, you have been vaccinated, but there is certain strain that came and infected you, and it evaded the protective response of the antibody. So that's why it is known as the escape mutants, right? Now, what is the most common mode of transmission? The most common mode of transmission is percutaneous. And unlike Hep C, you have got certain other mode of transmission. One of them is sexual. Hep B virus is almost found in almost all fluids. Right? So sexual is also an important mode of transmission. Perinatal, so you can have vertical transmission. Now, what do I mean by vertical transmission? If someone comes and asks you, well, what is my, if a mother comes and asks you that, what is my risk of transferring my hepatitis B status to my baby? So there are certain cutoffs that you can know. There are certain percentages that you can know. So if the mother is HBE antigen positive, then the transmission rate is 90%. But if the mother is HBE antigen negative, then there are 15% chance of transmission. Okay. When is the highest risk of transmission? The highest risk of transmission is at the time of delivery. So this is when you have the highest risk of transmission, right? Because at that point of time, the body fluids come into the contact with the baby. Okay. So previously it was mentioned that breastfeeding is contraindicated, but now there is no contraindication to breastfeeding. You can continue with the breastfeeding. But what is important to know here is the chronicity. If we look into the natural history of hepatitis B, you get infected with Hep B, it would go to acute or it would develop into fulminant. Once acute, if persistent, it can develop into chronic Hep B. But normally there is chance of clearance and only very less, approx 1% they develop chronic Hep B. And mostly it clears. But this is actually the function of age. So chronicity is basically the function of age. So if you have a neonate who is infected, if you have a neonate who gets a Hep B infection, there is a chance that 20 to 40% chance that patient would land up into chronic Hep B. But in contrast to an adolescent or young adult who develops Hep B, there is less than 1% chance of developing a chronic Hep B. Now we talk about the severity. Fulminant hepatitis B is seen, but it is also very rare. But if combined with HDV infection, the fulminant rate goes to 5 to 20%. Otherwise, fulminant hepatic B infection is very rare. But if it is combined with a hepatitis D virus, the fulminant rate goes up to the 5 to 20%. Okay. Now we'll discuss the serology part, which is very important, and this is from where you get questions in your exam. So guys, if you have acute hepatitis, and that you will get surface antigen to be positive, you will get hepatitis E antigen to be positive, HBe antigen to be positive, and you're going to get IgM anti-HBC to be positive. So all acute markers would be positive at this point of time. So this is acute. Now when we go to the chronic hepatitis, you will have surface antigen to be positive, and you're going to have either HBe positive if it is a highly replicating person, or anti-HB to be positive, it is a less replication is there. But your anti-HBC would change to IgG. What else you would get? In the window period, the question which is asked is, only marker that you get is IgM anti-HBC. If the patient is vaccinated, then you will get anti-HBS to be positive. Anti-HBS antibody to be positive. Now, if I add anti-HBC antibody with it, so anti-HBS positive, anti-HBC positive, that means your patient has recovered. And if there is a pre-core mutant, then if it is a pure core mutant, then your serology picture would be very much like a chronic Hep B. Who is less replicating type, who is less infective type. Okay, so chronic Hep B who is a less infective type. So what do I mean by that? You will get surface antigen to be positive, you're going to get anti-HBe to be positive, and you're going to get IgG anti-HBC to be positive, and HBV DNA viral load shall be increased. Now, when do you have a low-level Hep B carrier? Low-level Hep B carrier means your HBs antigen is there in the level or in the blood that is below the detectable range. So what you only get is IgG anti-HBC to be positive. So guys, in the window period, you had IgM HBC to be positive, and when you have a low level Hep B carrier, you just have anti-HBC IgE to be positive. Now let's just revise what we have read. So guys, whatever table I'm going to make here right now, it is very important from your exam point of view. So those who are listening to it, I would like to tell you, you sit with your copy and pen. You sit with your copy and pen and keep on practicing this, because more you listen to the lectures, when you are listening to the lectures every time, it's like it's very easy. It's very easy, and you think कि अब exam में mark कर लूँगा. But when exam in the actual scenario, when you are put up, when you are getting exact question in your exam, at that time the confusion arises. So what I want is, when you read this lecture, and you see this table, I would like you to practice with me for the first time. Write in a copy, practice, and after you are done, almost every week alternatively, what you're going to do is, you're going to write every antigen and antibodies that you can think of, and in the hepatitis B spectrum serology, and you will write plus minus करके, and accordingly you will determine कि किसमें क्या है क्या नहीं है. So the way you practice like this, you do the permutation combinations of different serological markers, you will ace in your exam. And in your exam, even if you have not read it recently, with your concept you can easily answer. Okay, so we come to the vaccinated. So a person who is vaccinated will basically have anti-HBs to be positive, and rest all would be negative. So a vaccinated person would only have anti-HBs to be positive. Now, person who is having an acute Hep B, his surface antigen would be positive. He is highly infective, so his HBE would be positive. At that point of time, anti-HBE can be positive or negative, but we are considering that the patient is highly infectious, so this is negative. IgM would be positive, and rest all shall be negative. When we come to the window period, only thing that is positive is IgM HPC. Rest all are negative. Okay. When we come to chronic Hep B, someone who is actively replicating, so the surface antigen would be positive, HBE would be positive, anti-HBE would be negative. The antibody has converted from IgM to IgG, so that would be positive, and anti-HBs would be negative. When we come to a chronic Hep B who is not infective, and we come to pre-core mutant, so pre-core mutant would be hepatitis B antigen would be positive, HBE would be negative, anti-HBE would be positive, this would be negative, this would be positive, IgG, HBC, and anti-HBs would be negative, right? So when you have a low level Hep B infection or a Hep B of remote past, only thing that you're going to get is the positive of IgG anti-HBC, IgG anti-HBC. So the only thing that you're going to get is positive IgG anti-HBC, and the rest of the stuff is going to be negative. The rest of the stuff is going to be negative, right? Next is when you have more than one subtype infection. Now, when you have got more than subtype infection, what's going to happen at that point of time is, so at that point of time, what you're going to have is, you're going to have positive surface antigen, and you're going to have positive anti-HBs also, and positive HBE. So simultaneous presence of a surface antigen positive and simultaneous presence of anti-HBs positive in a patient should make you think that there is more than one subtype that is infected. And we have one more condition, if there is a recovery. So if there is a recovery, what you can get is your anti-HBs would be positive, your anti-HBs would be positive, and your IgG HBC would be positive. So that is basically the chart for entire serology of hepatitis B infection. Next, we're going to start with hepatitis D virus infection. Now, hepatitis D is also known as the delta hepatitis. Since we are reading the serology of Hep B, I would just like to add to it the serology of the delta hepatitis here, because you get a lot of questions from here. So one point you have the co-infection and the other is the super infection. So when you are having a co-infection, that means you are having a HDV with acute Hep B, and super infection means HDV with chronic Hep B. So this is the basic difference that you need to remember, and accordingly you will be able to answer the serology in the exam. So when the HDV is positive, you're going to get HDV RNA to be positive, and so HDV RNA would be positive and anti-HDV would be positive. Anti-HDV would be positive. What else you're going to get from hepatitis B is IgM. Anti-HBC would be positive, right? IgM anti-HBC would be positive. And when we talk about a chronic super infection, in that case you would have HDV RNA to be positive, anti-HDV to be positive, and here you will get IgG anti-HBC. So that's how you can differentiate whether your patient is having a co-infection or a super infection, right? Now if we just go through this table, this is a very important table from the Harrison. What is important here to know is HBV has got an incubation period of 30 to 180 days. Similarly, HDV also has got the same incubation, because it needs actually hepatitis B to infect. So the same incubation period. What is important to remember is the percutaneous route in both. And HDV is more commonly seen in IV drug abusers. But what you need to remember is the fulminant rate. In hepatitis B, the fulminant rate is only 0.1 to 1%. But look at the fulminant rate here. It is 5 to 20%. So I would like you to know one MCQ is most fulminant hepatitis is Hep D. Most fulminant hepatitis is Hep D. And most fulminant hepatitis in pregnancy. Most fulminant hepatitis in pregnancy is Hep E. Where the fulminant rate increases from 1 to 2% to 20%. From 1 to 2% to 20%. Now what you have to remember is, when we are talking about a neonatal infection, I mentioned you 20 to 40% would develop a chronic infection. 20 to 40% would develop a chronic infection. And in case of your carrier rate, when a neonate is infected, right? So if you have a HBe antigen positive mother, there is a 90% chance that the neonate would be infected. And if it is a HBe antigen negative mother, there is only 10 to 15% chance that the neonate would be infected. So this is the very important, some of the epidemiology data that I have covered here, right? Now next important thing would be who are at high risk of acquiring hepatitis B virus infection. So there are certain group of patients: Down syndrome, Hodgkin's lymphoma, polyarthritis nodosa, patients with leukemia, those who are CKD without dialysis, those who are on hemodialysis, IV drug abusers, the spouses of patients who are Hep B, and you cannot forget the hemophiliacs and the healthcare workers. We, the healthcare workers, are also at risk of getting hepatitis B from accidental needle stick injuries. Now, what I need to remember, what I would like to also tell here is important number. So if you take a cohort of polyarthritis nodosa, you would see that 20 to 30% of the polyarthritis nodosa, they have got a positive surface Hep B antigen. But if you take it general, if you take the cohort of hepatitis B virus, hepatitis B antigen positive patient, only less than 1% would have polyarthritis nodosa. So this number needs to be very clear that if you take a cohort of PAN patients, I have total of this much PAN patients. Among those, 20 to 30% would be Hep B positive. But if I take a cohort of total people of Hep B positive, among that only less than 1% would be having PAN, right? Now, previously, the transfusion-associated hepatitis, there was a lot of risk with hepatitis B. But now with the stringent monitoring that we have, the risk has reduced. So if you say that if you're getting hepatitis B due to transfusion related, then you are very unlucky, because now the risk that is mentioned in Harrison is 1 in 3 lakh. So 1 in 3 lakh is the risk of acquiring Hep B infection from blood transfusion. Okay, so this is important. Next is about the clinical features. What do we get in acute hepatitis? Acute hepatitis usually starts with a prodromal phase. So you're going to have fever, loss of appetite, nausea, vomiting, right? Nausea, vomiting. So this is important, whether the fever comes first followed by jaundice. So if this is the scenario, then you suspect mostly viral hepatitis. But if the jaundice comes first, followed by fever, especially in the clinical round, then you have to think of cholangitis. So what happens in the icteric phase? When the icteric phase comes, the fever is gone. So this is the phase where you start having jaundice. So since it's a hepatocellular jaundice, what you're gonna get is clay-colored stools, dark urine. You're gonna get clay-colored stools, dark urine. Why? Because there is increased conjugated bilirubin. This being water soluble, it can come to the urine. Next is you're gonna get pruritus. You're gonna get elevation of aminotransferases. Now, aminotransferase might be elevated between 400 to 4000. Now, if you get such kind of LFT reports where the number is more than 1000, then you think of only 3 causes. One is viral hepatitis, second is drug-induced liver injury, and the third is your vascular injury to liver. Okay. Next is the ALK phos would be normal or mildly elevated. And if you want to do a quantitative method of DNA replication, you have to do a quantitative method to see how much of the Hep B DNA is getting replicated. Then you go for the HBV DNA levels, and whatever the methods that we employ, the sensitivity is it can detect up to 10 to 5, 10 to 6 virons per ml. It has got the sensitivity of 10 to the power 5, 10 to the 6 virons per ml. That is the sensitivity. Now we come to the treatment part. The most important is a post-exposure prophylaxis. So suppose you get a needle stick injury. in a ward with HBs antigen positive patient. Now there can be 2 status, either you are vaccinated or you are unvaccinated. So if you are unvaccinated, you have to go for both passive and as well as active immunization. You would go for the Hep B immunoglobulin, and you're gonna go with the Hep B vaccine. Now, if you are vaccinated, what you need to do is you need to check your anti-HBs titer. If it is more than 10 milliunits per ml, then you need not to worry and do anything, right? So again, I'm telling the post-exposure prophylaxis varies according to whether you are vaccinated or unvaccinated. If you're unvaccinated, then you have to take both passive as well as active immunity. Passive plus active immunization, right? But if you are vaccinated, just look for the titers. If the titers are elevated, you don't have to do anything, okay? Next, we'll start with what is known as the chronic Hep B. So chronic Hep B, I've mentioned, is the function of age. It's inversely related to age. So if you have got a neonate who is infected, he has got a high chance to develop chronic Hep B. He has got a high chance to develop chronic Hep B, right? But if it is an adolescent that is infected, adolescent who is infected, then there is a less than 1% chance that patient would develop a chronic Hep B, because unlike Hep C, this virus does not really lead to chronicity. But what is the important factor that can drive chronicity and can lead to the development of dangerous complication, that is hepatocellular carcinoma? It is the degree of hepatitis B virus replication. It is the degree of hepatitis B virus replication that can give rise to formation of hepatocellular carcinoma. So whenever we are actually treating for a chronic Hep B, we divide into two categories. One where you have a HBe antigen positive or not, and other is when you have the anti-HBe positive. So this is basically the person who is infective and replicative. It is the person who is having a replicative form of hepatitis, or you can say he is having a chronic active hepatitis. So in such cases, when you do a quantitative DNA estimation and the number comes to be more than 2 into 10 to the power 4, 2 into 10 to the power 4 international unit per ml, along with that ALT is elevated to more than 2 times, then you have to start with treatment. So if the ALT is elevated more than 2 times, plus your Hep B DNA is 10 to the power 4 unit per ml, then you start with the treatment. Whereas when we are going for this variety of patient, we have reduced the cutoff. We have made the cutoff 2 into 10 to the power 3 unit per ml with 2 times elevation of ALT. That's the indication for starting treatment. So starting treatment indication 2 into 10 to the power 2, twice the power of ALT elevation, is same for both categories. What differs is the degree of DNA replication. For one, it is 2 into 10 to the power 4, and for the other is 2 into 10 to the power 3. So that we need to remember. Now, what about the inactive carriers? If you have a normal ALT levels, you do not have a Hep B positive, HB antigen that is positive, you have anti-HBe positive, and you have normal ALT levels. So in that cases, you do not need any treatment, and your HBV DNA is below the detection threshold. Right? So you do not need treatment in those cases. Now, what are the drugs that we have for treatment? We have entecavir, we have tenofovir alafenamide, and we have TDF, that is tenofovir disoproxil fumarate. So these are the drugs that we have for chronic Hep B. We gave it for a duration of somewhere around 48 weeks, right? So this basically brings us to the end of the module on hepatitis B. What is important here is the serology. Every exam, if you have any question from Hep B, it will be from the serology. They'll ask you different types of question on serology. Seldom they ask you about the treatment part, but serology is very important from this entire module. I hope you have enjoyed this module. Thank you.